Right, it is 12:02. Let's get started. Hoping everyone can see and hear everyone okay. If not, please do shout in the chat function, the Q&A function. So let's kick it off. Welcome everybody to today's webinar. Thank you for giving up your lunch break. This is 45 minutes today for our session. I'm Lucy Diamond. I'm Clinical Director for Innovation here at Oviva. I've been here since the birth of Oviva UK, so back in 2015, 2016, and I'm a diabetes specialist dietitian by trade. I worked for almost a decade in the NHS before joining Oviva, and it is a pleasure to be here today sharing this call. So as you'll see, I'm joined by two colleagues on the panel today for the webinar who have a wealth of experience both within the NHS and at Oviva, and specifically in diabetes. So both Karen and Neil will introduce themselves as we go, and we're here today to explore together the question, unlocking better outcomes and return on investment, is diabetes structured education the key? So quick bit of housekeeping before we get started. We all know the drill by now. Please pop your microphones on mute, get comfortable, settle in for the next 45 minutes. Please put your cameras on if you feel comfortable to do so. It's great for our speakers to see a sea of faces. Today's session will be recorded, and that recorded I can see has started, and this will be shared and circulated after today's session. And then final thing from me is please do ask questions in the Q&A function as we go. So along the top bar, you'll see there is a Q&A function. If you can pop all of your questions in there, and we'll make sure we save some time at the end to get to those questions for Karen and Neil. So without further ado, let's get started. So agenda for today, I'll start very briefly by introducing Oviva, if we are yet to meet. Then Neil will take us through the current landscape in diabetes. Karen will then deep dive into Oviva's diabetes education offering. I will explore briefly education as a concept in general. And finally, Neil will examine why it's so important to invest in diabetes structured education, both of its impact to patients and to NHS. So, as promised, very briefly, who are we, Oviva? So, headline, one of the leading providers of diabetes and weight management services for the NHS, and that is solely providing services to the NHS. We are one of the key digital providers in 3 national programmes, so diabetes prevention, diabetes remission, and Tier 2 weight management. And we also provide services commissioned locally throughout the UK, predominantly in Tier 3 and diabetes structured education, which is the focus of today. So Oviva has grown significantly in the last few years in my time here. We now provide services in over 3/4 of ICBs and or health boards in the UK. We serve over 8,000 patients per month, and that's more than 200,000 service users who've taken part in our programmes to date. And we are run and led by healthcare professionals, as you can see on our panel today. And at the heart of what we do is really supporting patients to reach their goals. And we love nothing more than to sing about those. So there you'll see we have over 62 publications to date. And all of those publications and links can be found on our website if you want to do some further reading on those. So how does it work? Very briefly, we have actual humans delivering care at the end of our technology. We leverage our technology, mainly predominantly our app, to improve the access to those humans. So as a communication tool, but also as a tool in itself to support that longer term behaviour change. And Karen's going to take us through our approach in a little more detail shortly. Final slide. Before we delve deeper into today's talk, I just wanted to set the scene and highlight that here at Oviva, diabetes structured education is where it all began for us. It was our first programme delivered in Buckinghamshire back in 2016. And I'm really hoping today we can bring some of that experience of our journey and discuss why diabetes structured education remains a focus and priority for us here. And to kick that off, I'm going to hand over to Neil. Thank you, Neil.
Thank you, Lucy, and good afternoon, everyone. Just to introduce myself, I'm Neil Gupta. I'm medical lead at Oviva, and I'm a GP by background. I've been a GP for a long time, but alongside that, for the last 12 years or so, I've been very heavily involved in commissioning and was previously the chair of Camden CCG in North London. So I bring three different perspectives really to the challenge around diabetes and diabetes structured education. Firstly, as a practicing GP. Secondly, as an NHS commissioner. And thirdly, and more recently, as a provider of diabetes structured education and treatment services. Next slide, please. So it seems that almost every couple of weeks we see a new story in the press about the explosion in type 2 diabetes. And this is one just from a couple of weeks ago, which suggested that approximately 1 million people may be living with type 2 diabetes and may not be diagnosed. And a lot of people are using the term a diabetes crisis, and I would absolutely agree with that. I think we are seeing this explosion in type 2 diabetes, and it is a crisis. But I think almost type 2 diabetes has become so common that we're becoming slightly desensitized to it. And I think you still see amongst healthcare professionals people talking about you have a bit of diabetes or being diagnosed with diabetes and being told that it's nothing to worry about. But if I diagnosed you with any other condition and told you that you have a significantly increased risk of heart disease, strokes, blindness, chronic kidney failure, dementia, cancer, you would very rightly be worried. And one of the things that I feel very passionately about is that we need to be having much better conversations early on after diagnosis of type 2 diabetes, where we are saying you have type 2 diabetes, it's extremely serious and can lead to very significant health problems. But the good news is that it can be fully reversible if you make the right changes, but we need to act early and you're going to need support to do that. And that's exactly where Oviva Diabetes Support comes in. So next slide, please. And so if we're using this language around a diabetes crisis, what do we mean by that? Well, let's just look at some of the numbers. So it's estimated that around 5 million people or over 5 million people are now living with diabetes in the UK. And that's estimated to grow to a staggering 1 in 10 people by 2030. Much of that mirrors the rise in obesity that we've seen over the last 20 years or so. But I really want to draw your attention to the middle row, which is a trend, an alarming trend that we're only really just starting to take seriously, I think. And that's the fact that type 2 diabetes is being diagnosed at younger and younger ages. And we're seeing really an explosion in the number of people who are under 40 being diagnosed with type 2 diabetes. And I'll come on to why that is so alarming in a minute. Next slide, please. And so I'm sure most people on this call will be very familiar with this slide. It really just talks about what is the health impact for the individual of having type 2 diabetes. And I think most people are very familiar with the increased risk of heart disease and strokes, the increased risk of kidney disease, visual impairment. Perhaps less familiar that there is a significant increased risk of dementia with type 2 diabetes, and less familiar that there are significantly increased risks of many of the common cancers, such as bowel cancer or breast cancer. But really, again, I just want to focus your attention on the right-hand side and that under 40s group. So generally, the earlier you are diagnosed with type 2 diabetes, the more dangerous it is, and especially for that under 40s group. And conversely, people who are diagnosed with diabetes later in life, in their 70s or 80s, the impact of that type 2 diabetes is likely to be far less. What we know is that the people who are diagnosed at an early age, particularly those under 40s, have a more aggressive form of the disease. It is more rapidly progressive, and they are at much higher risk of complications from the type 2 diabetes. And so all of that means that if you are diagnosed with type 2 diabetes under the age of 40, you have a 7-year reduction in your life expectancy compared to someone of the same age without type 2 diabetes. So for me, we need to be throwing absolutely everything we have at those working age people, especially the under 40s who are diagnosed with type 2 diabetes, and helping them to reverse their condition early on. Next slide, please. So we talked about the impact on the individual. What's the impact of type 2 diabetes on NHS services? And I think that top left box nicely illustrates this. If you look at the hospital inpatient population, at any point, 1 in 6 people admitted to hospital will have diabetes. And those people who are admitted to hospital with diabetes have a higher mortality, longer stays, and a higher risk of readmission. What we saw during COVID really was a collapse in the level of proactive and preventative care for type 2 diabetes in primary care. And we can see that in terms of the number of people who receive their proactive 8 care processes dropping from 59% to 37%. And we can see that in the drop in the achievement of those 3 treatment targets, the blood pressure, lipid management, and glucose control. There is some recovery since then, but we're nowhere near back to where we should be. And clearly the knock-on impact of that is if we're not delivering that proactive and preventative care, or we're not delivering it at sufficient quality, then people are at risk of further deterioration, further complications, and that's further pressure on secondary care. Next slide, please. So final slide for me in this section, and that's just really to consider the financial impact of type 2 diabetes. And given what we've said about the individual impact and the impact on health services, not surprisingly, type 2 diabetes has an enormous financial impact on the system. It's difficult to get exact figures sometimes, and I suspect a lot of this are underestimates. But what we do know is that approximately 10% of the annual NHS budget is spent on type 2 diabetes. That's around £10 billion per annum. And common to many long-term conditions, this is not just specific to type 2 diabetes, it applies to heart failure, COPD. The bulk of the money we spend is reactive spending on the complications of type 2 diabetes, rather than that proactive investment in preventing those complications occurring in the first place. And then the final comment on the left really is going back to those non-elective admissions. So for people living with type 2 diabetes, a population living with type 2 diabetes, the non-elective admission costs are 4 times higher than a similar population without diabetes. And then final point from me is really just to focus on trends in prescribing. So we know that already prescribing for type 2 diabetes takes up a significant chunk of the NHS prescribing budget, and it's already over £1 billion per year. But what we're seeing is that there is a rapid increase in prescribing spending for type 2 diabetes. And for me, there are 2 reasons for that. One is the increase in prevalence that we've already talked about. But secondly, we've seen the advent of newer medicines for type 2 diabetes that are extremely expensive. So an SGLT2 inhibitor will cost around £500 per year per patient. And the GLP-1 medicines, which we're hearing a lot about in obesity, but have been used in type 2 diabetes for much longer, will cost around £1,000 per patient. So that's £1,500 per patient per year, just for those 2 medicines. And so as a result, we're seeing a huge expansion in the prescribing budget for type 2 diabetes. Next slide, please. And over to Karen.
Thank you, Neil. Thank you for setting the scene so well. I hope I bring some optimism, because that sometimes feels quite stark. But before I do that, let me introduce myself. My name is Karen Miller. I am a diabetes dietitian by background. I've been a dietitian for just over 20 years, which feels far too much to really admit out loud, with the majority of that being in specialist diabetes and in the NHS, as someone who has delivered traditional diabetes education, but most recently my time has been in as one of the real people that Lucy alluded to, working with people referred to us at Oviva. So I'm hoping I can share some of that with you. Thanks. Next slide, please, Holly. So Neil did mention the absolute huge scale of type 2 diabetes as a problem. But if we just take a minute to unpick that, within those huge numbers are individuals, and for every single person, their story is different. Not only is the pathophysiology complex, it might be a little bit different for each of those individuals. And then let's layer in life on top of that. Not only have these people been diagnosed with type 2 diabetes, they will have huge amounts of social stress. They might be holding down a variety of jobs or just can't find a job. Their literacy levels might be quite low. They might have high BMIs, exceptionally high BMIs, but equally they may not. They might have a variety of comorbidities, and with that, so much medication that's prescribed. And then sometimes those medications that have been prescribed add extra complications. So for example, a hypoglycemia risk. And then on top of all of that, their mental health isn't great. So we have this Huge problem. It's a huge scale of a problem, but within that, every individual has a very, very personal and complex journey. Next slide, please, Holly. How do we manage that? And NICE very well-meaningly launched their statement back in 2011, and it has been updated more recently, saying that adults with type 2 diabetes should be offered structured education at diagnosis. And that's right, because we need to be able to take all of that complexity and give these individuals the knowledge and skills to be able to go and manage their life, their diabetes, in a way that's right for them. And if possible, we should be able to bring family members along with them, and it should be offered at that time of diagnosis, because hopefully we'll have someone super motivated who's open to making those changes. So a really nice, well-meaning statement by NICE. However, the reality is that those are not always well received or able to be received by our individuals. Thank you, Holly. Next slide, please. So we find that someone is often quite overwhelmed. They've just had this diagnosis of yet another thing that they now need to build into their life. They need to take time off work to see their practice nurse. And now they've got to take time off work to attend traditional structured education. They're often quite in shock. This is not news that they'd hoped to receive. They're sitting in a room looking at people who look different to them. It's a few hours that they've had to take out of their day, and they're overwhelmed by the amount of information being given to them. And then they do remember a question that they need to ask, but they're a little intimidated, or perhaps they're now no longer in that traditional setting and able to ask that clinician the question that they've always wanted. And so what we tend to find traditionally is that, unfortunately, the uptake of these traditional offerings does remain quite low. However, we think we have a really useful, innovative solution that might help to solve some of these problems. Thank you, Holly. So this is Oviva's diabetes support. Now, every individual referred to us will have an initial assessment and a personal onboarding journey. That means we can then provide and tailor personalized care and deliver structured education to them in a way that's right for them. So people can choose whether they'd like this to be received via telephone calls, whether they'd like to receive it via our app platform. Would they like to receive care individually, one-to-one, or would they prefer to mingle with other people who are going through something similar to them? Because of the way we work, we can offer a tailored solution to individuals. We can match them with someone who's culturally a little more similar to them as their coach. So providing their care in a language that's right, but also with that cultural sensitivity as well. We can offer appointments that are really flexible and in evenings, on weekends, at times that are right for them. And those conversations don't always have to be live. So if you've got someone who works shifts and is logging a meal or has a question at 3 a.m. in the morning, because that's when they're functioning, they can do that. And then they'll be able to receive the care and support from their clinician at a time that's then right for them as well. All of this support means that we are able to show really significant weight loss with improvements in glycemic control as well. Everyone gets free access to our digital tools, and I'm about to show you a little bit more about what that might look like. Next slide, please, Holly. So put yourself in the seat of someone just diagnosed with diabetes, or if it's not you, it's someone who's near and dear to you. Instead of having to take time out of your day, the care is in your back pocket. The care comes to you. And because of this lovely, really easy to use tool that's now at your fingertips, you can set yourself targets. You can work with your coach to set targets that are right for those health goals and that social complexity that you have to take account of. And you can track and you can become accountable, not just to your coach, but to yourself. That act of self-tracking is really powerful. But then there's someone who is giving you feedback, comments, support, praise, maybe some suggestions, maybe some tweaks, totally relevant to you. So it's really, really personalized. And if you've got a query or perhaps a question or something that you want to explore and share, you can write a message to your coach, and you know that they're going to pick that up and they're going to be able to give you that feedback in a way that's really private, that you could then maybe sit down with your loved one and share and go through that with them. There is nothing more powerful than using someone's own data to support their journey. they're able to isolate what is happening with them. So, for example, in the graph that you've got there in front of you, as their weight is coming down, they could then layer in what is actually happening to my blood glucose and my blood pressure as well. That's much more powerful than giving a flyer that says, go and lose weight because your blood glucose and blood pressure will come down. So using someone's own data to really drive that behavior change is so powerful. And then there is the learned content that people can access in small bite-sized chunks, manageable chunks that they can revisit and they can go over again and share with the people that in their life that might need to see that as well. That is totally, totally relevant and supportive, freeing up their coach to then do the stuff that's really personalized and individualized to them. They have access to this, not just for the 12 weeks that they're with us, but ongoing access to this beyond their 12-week journey. Thank you, Holly. Next slide, please. So I hope you can see how excited and passionate I am. And I come from someone who has delivered those traditional services within the NHS. This is just such a different way of working. And HSJ feels as excited, and they awarded us with an award for most impactful project addressing health inequalities. And that's, I think, what really excites me, is that this is a way for us to get care to people who struggle to receive this care, who don't usually access it. As Neil mentioned, we're seeing far more young people being diagnosed. They work, they can't take the time out. They don't want to go and sit in a room with people who are twice their age. So we've got to be able to bring this care in a really different way. So I'd like to show you this as a case study to highlight how that can work. So in Barking and Dagenham, which is where we got this HSJ award for, they have a very complex community. They've got more than 14,000 people living with type 2 diabetes. This is back in 2019, 2020. 70% of those people were offered diabetes structured education, as they should, but less than 11% actually attended it. Now, this is a population where of those with type 2 diabetes, 53% are from ethnic minority groups. They speak a variety of different languages, but they had very little choice in terms of how they could receive the care that they needed, the information that they needed to go and manage their diabetes well. Thank you, Holly. So these are the outcomes. So 72% of people who were referred to Aviva Structured Education attended. That's in contrast to that 10.9% a couple of years before that. 76% of those people were from an ethnic minority background, so much, much higher uptake than we'd seen before. And in just a short 12 weeks, on average, people managed to lose just over 3 kilograms in weight. And 80% of ethnic minorities went on not only to attend, but actually to complete the program as well. So just, it really, really worked for them in a way that felt right for them. Now, not only were these great clinical outcomes achieved, we saw an increase in people's own confidence. Now, if I go back to that initial nice statement, this is about people being able to go and feel well, feel like they can manage this on their own. And their confidence increased from a baseline of 6 out of 10 to 10 out of 10 once they've done that. Some of the reason for that is we were able to deliver this care in 10 different languages just in-house. So we really were delivering care in a way that was right for that community. Thank you, Holly. So not only were there these clinical outcomes, we also managed to have a huge impact financially. So we saw in-year cost savings per participant of £353, and that was rising to over £1,000 over those 5 years. And we saw that from reductions in access from patients requiring both primary and secondary care. But as Neil highlighted, those diabetes meds are not cheap. So a reduction in that need for all those expensive medications. Because of the scale of the problem, we delivered a £354,000 in-year cost savings for Barking and Dagenham. And that came from those prescribing, reducing in those prescribing costs, but also reductions in service pressures as well. So thank you very much. And I think it's back to Lucy now.
Amazing. Thank you, Karen. And thank you very much, Neil, for setting the scene and leading us into that, Karen. I'm just going to flag the Q&A function. So if you have got a question from anything that's been covered so far, please do pop it in the Q&A and we'll make sure we get time to come to that. So moving us forward, and I know Karen has really clearly outlined how a remote or a digital diabetes education programme is required to be added to the mix to make sure we have a suite of offerings for patients to improve the uptake and attendance for diabetes structured education. But I want us to think of what could be one of the reasons why historic uptake of diabetes education has been low, and possibly how it's framed, how it's positioned. And I want you to do some work now, sorry. I want you to get interactive with us. If you can click on the Mentimeter, I want you to think and put in the first word that comes to your head when you hear the word education. And that could be in the context of diabetes or outside, but just that word education. What comes to mind when you hear that word? This is where I breathe a sigh of relief that the tech hasn't failed. Hallelujah. Amazing. A few moments. Thanks, everyone. So some of the words coming in: classroom, school, learning. Great, I love it. There's a positive in there too. Info overload, one size fits all, that teacher relationship, mandatory, awareness, that's a positive word, power, top down, knowledge, absolutely, clarity. So we've got a mix there of some of those positives, but some of those conventional ideas around what kind of the word education ignites in us, that classroom feeling, that teacher, that at school learning positioning. Thank you, everyone, for taking part. I'm relieved. So when we think of that word education, so that ignites some mixed feelings in our minds, and we know that NICE highlights that education, as someone calls it out in that piece there, is about providing people with knowledge. But NICE also frames it as the skills to manage chronic condition. So we really need to change that thought, that narrative, that education is about sitting in a classroom, learning about your diabetes, to really selling it to individuals as a course to support you to change your behaviour and potentially your path of your diabetes in the future. So when it comes to diabetes education, I know many people in the room may have delivered this. We know that diabetes education is much, much more than that knowledge base. As I said, in order for someone to change their behaviour, as the COM-B model tells us, we need capability, we need motivation, we need opportunity to change behaviour that has the biggest impact on that future path of diabetes. So empowering someone with knowledge is just one aspect, but we need more than that. And as I said, many of us in the room know that diabetes education is more than that. So should we reframe the wording, the use of the word education, and call it a course to support you to manage your diabetes and self-manage your diabetes? So next slide, please. So looking at that reframing and calling our course diabetes support rather than diabetes structured education does a 12-week behaviour change programme that encompasses education get the results that you'd hope to see. And hopefully we can demonstrate that with some of our outcomes here. So looking at the uptake there, the completion, and the outcome metrics for weight and HbA1c that I hope you'll agree are significant. So step one is to change that narrative around education. And then step two is to really address access and to support and empower people living with type 2 diabetes to self-manage. And just flagging here, there was a really incredible Diabetes UK survey last year with 13,000 responders that flagged that almost 50% of people who responded to the survey expressed that they really struggled to manage their diabetes. And 50% of people put this down to lack of access to their healthcare team. And the results were actually even more pronounced in responders who were living in social deprivation. Which brings me to my final slide. So I know this has been mentioned, but whilst we're likely at the moment to get distracted by shiny new things such as GLP-1s and weight management, let's not forget the scale of diabetes in the UK and how important it is for care, treatment and support to remain a priority, which leads us on to why commissioning a diabetes structured education service is so important. And over to you, Neil, for this.
Thank you, Lucy. Yeah, I'm just going to finish with this last segment. I'm just going to focus on some areas that are relevant to commissioning, and in particular, I'm going to focus on the finances, and return on investment, which I'm sure will be of interest to a number of people on this call. Next slide, please. I think we've alluded to this, but this slide just really shows that uptake of traditional diabetes structured education has always been poor. And we saw a drop off, like many of the other parameters. We saw a drop off during COVID and perhaps a slight bit of recovery, but uptake remains poor. And I think Karen and Lucy have already alluded to some of the reasons why that is. And a lot of that is in terms of how diabetes structured education has been commissioned and how it's been delivered. So we've talked about really our target population is a working age population. So but we tend to commission services and deliver them at fixed locations during working hours. And it's no surprise then that the people we want to target can't access those services due to work commitments, due to shift work, childcare commitments, other caring duties, transport, parking, etc. And I think hopefully that's sort of well understood. I think for me, there is a more subtle reason why uptake for structured education is poor. And I think certainly as doctors, we often perceive diabetes structured education as a tick box exercise, and we often perceive it as something of a lightweight intervention when we compare it to some of the medicines that we prescribe. But if you think about it, a person living with type 2 diabetes will spend 1, maybe 2 hours with their healthcare professionals during the course of a year, and they'll spend the other 8,500 hours not with their healthcare professionals. So if we can empower people with the knowledge, but as Lucy says, the skills to reverse their own diabetes, to utilize that time that they're not with their healthcare team, and we support them to create new habits around diet and around physical activity, then the clinical outcomes we can see from that can be comparable to any of the medicines that we prescribe. Next slide, please. And so really just to illustrate that point, what I've done here is just to list some of the commonly used newer medicines that are out there, and just to show what the approximate reduction in HbA1c might be through those medicines along with the cost. So if we use a medicine like a gliptin, if we use something like linagliptin, we might expect to see a 7 millimole reduction in someone's HbA1c. But that would cost you around £400 per year for that person taking the medicine, and clearly that benefit in terms of HbA1c is only relevant whilst the person is taking the medicine. As we know, people don't always continue to take their medicine. And as we can see, as you go further down this table, the drugs become more potent, and with the SGLT2 inhibitors and with the GLP-1 agonists, but they also become more expensive. So something like liraglutide, which is a GLP-1 medicine, and we use it also in weight management, but it's been used in type 2 diabetes for much longer, you might expect around a 12 millimole reduction in HbA1c, but that will cost approximately £1,000 per year per patient. And what I've done is I've just put Oviva's diabetes support program alongside those medicines. And what we can see, and this is data that Lucy showed earlier, and it's data that we presented at the ABCD conference a couple of years ago, to show that on average, people going through our program could expect to lose around 14 millimoles, reduce their HbA1c by around 14 millimoles per mole. And as you can see, that's at a fraction of the cost of some of the medicines that are out there. And I think it's really important to try and understand why that is. And I think that's because, as Lucy and Karen have both alluded to, our diabetes support program is not just a structured education program. It is not just about giving people information or being in a classroom setting. It is about giving people the information, but then supporting them to turn that information into meaningful change. So by providing that behavior change support and that personalized coaching to support them to create new habits around diet and around physical activity, we start to see those really impressive clinical outcomes that are comparable to the medicines that we prescribe as doctors. And just to illustrate that point, I've just put healthy living with diabetes as the bottom row there. So I think most people on the call will be familiar with healthy living. This is the national tool that's been commissioned by NHS England, supposedly as a structured education tool, but it is essentially a website. So it is a website providing static information about type 2 diabetes. And the study on which this was based, this decision from NHS England to purchase Healthy Living, showed that people going through that programme lost on average less than 1 millimole per mole, reduced their HbA1c by less than 1 millimole per mole at the end of the program. And I think that just shows the limitations of just providing information. That in itself will not help us to achieve the clinical outcomes we're looking for. And for me, it's really important. One of the takeaway messages is that a tool like Healthy Living is just not comparable to Oviva's diabetes support in terms of the clinical outcomes that we're aiming for. Next slide, please. Okay, I'm going to just switch now for the last bit, and I'm going to talk about money, and I'm going to talk about return on investment, because I know that will be of interest to a lot of people on the call. Lucy's already mentioned that we've been delivering diabetes support for a number of years. So quite a few years ago, we partnered with an economics consultancy, Frontier Economics, to analyse and model the return on investment for commissioners who were interested in commissioning our diabetes support programme. Frontier Economics have been making a lot of the press recently. They're doing a lot of work around the economics of obesity, and they've partnered with organisations such as the Tony Blair Institute and companies such as Novo Nordisk. So the exercise that we did with them was very detailed and very rigorous health economic modelling. Next slide, please. And what did that show? Well, it showed that for an individual going through Oviva diabetes support over a 3-year time frame, we can expect to see for the local area a return on that investment cost savings of £750. So that's a approximate 6 to 1 return on investment after a 3-year time period. And as we go further out towards 5 years, the savings are around £1,000. And what's really important to highlight in this is that those savings are front loaded. So the bulk of the savings come in years 1 and 2. And the reason for that is that this is a realistic model. So I've shown, and Lucy's shown, some of the weight loss figures that we expect to achieve and some of the HbA1c reductions that we expect to achieve. But we recognise that over time, many people will start to regain weight. Many people will start to see their HbA1c potentially increase. So this model is realistic, and it's modelled on what does the trial evidence tell us is the natural trajectory of people's weight and HbA1c after an intervention like this. So you can start to see that some of the savings do tend to drop off, and a lot of the savings are front loaded in years 1 and 2. But at a point in time where pretty much every ICB is in financial difficulty, I don't think it's any harm that those savings are early in years 1 and 2. And whilst I've talked about Oviva diabetes support as a highly effective treatment, you could perceive it as a cost-saving initiative. And at a time when everyone is looking for cost savings and system efficiency plans, this is certainly an initiative that could slot into a system efficiency plan for an ICS. Next slide, please. So where do those savings come from? No surprise, really, given what I said before about the impact on secondary care of type 2 diabetes and the fact that secondary care is the most expensive part of the system. The bulk of the savings come from reduced secondary care utilisation. A small amount comes from reduced primary care utilisation. And in this model, a small amount comes from prescribing. But I do need to make a really important point, is that the savings that commissioners could expect if this was commissioned now would be significantly higher than those outlined here. And the reason for that is that this model was created in 2018 and it used NHS costs from 2016-17, which have clearly risen significantly since then. So if you prevent one admission from happening for type 2 diabetes now, you will save a lot more money than you did back in 2016-17. And you know, there's a really important trend that I've already outlined around prescribing. So when this model was developed in 2018, those newer, very expensive agents, the SGLT2 inhibitors, the GLP-1 agonists, just weren't in common use at that point. But we know now, if you prevent the escalation of someone's diabetes to the point where they no longer need an SGLT2 inhibitor and a GLP-1 agonist, for that individual alone, you will save £1,500 per year for the system. So the prescribing savings in this model are a dramatic underestimate because of that changing landscape around prescribing. Next slide, please. Okay, and just to finish from me, just to summarise then that last section, structured uptake of traditional structured education is poor, remains poor, and is highly variable. But we know that just education and information alone will not help us to achieve the clinical outcomes that we're looking for. And Oviva's diabetes support is much more than just structured education. It is provision of that education alongside behaviour change support and personalised coaching, which allows us to achieve those clinical outcomes. And therefore, I would think of it as a highly effective treatment for type 2 diabetes rather than just an education programme. It's highly effective, but it's also highly cost effective, especially when you think about the cost of those comparable medicines. It's not just cost effective, it's cost saving. And we've talked about those significant savings that are delivered quite early on. And as a result of those savings, it is possible to utilise diabetes support as a cost saving initiative for ICBs that are interested in that angle. And that's it from me. Back to you, Lucy.
Amazing. Thank you, Neil. And I think that's a really powerful summary to end on. So I'm really aware of the time and we have a few questions. So I'm going to do the speediest quickfire round of Q&A. Ellie, I really hope that the final slides there from Neil may have answered your question around how we worked out the financial savings with the Frontier Economics model. If it didn't, then please do reach out again. But I'm really hoping your question preempted Neil's Frontier Economics. Looking at a question from Ayaz, do you offer a single point of access? Karen, can I come to you for that question there, if that's all right?
Oh, we've tried different things and we're willing to try different things. So in some places, the GP can refer directly to us. In other areas, patients can self-refer. And in other areas we've done where it's kind of gone to the main face-to-face provider, and if people haven't wanted that, then those patients have come to us. So we are willing to try a variety of different things. Within our team, our onboarding team, we've got a fantastic team of patient coordinators who, when we receive that referral, will make contact with that patient within 7 days. The truth is, it's probably sooner than that. And that is such an important part of getting people on board. You've got them excited, you've got them worked up and motivated. There is nothing worse than them sitting on a waiting list or in an inbox. So we will reach out to them really quickly. And because of the way that we work, we can get them started on this journey really fast. So happy to work with the area in a way that's right for them.
In the final 30 seconds, Karen, can I keep you unmuted? Are any Scottish health boards utilising Oviva to provide education? Asked by Cheryl. Thank you.
Yes. So we have a DSE service in Tayside, which is doing really, really well. And then we have some other weight management service. I think we've got a tier 3 service up in Scotland as well. So definitely a presence, and would obviously love to help even more people who live in Scotland.
Amazing. Thank you, Karen. And I think that concludes today with a final 10 seconds or less to go. Details to contact us on there. You can screenshot that QR and it will take you to a link to book in with Elliot or Louise. So please do reach out and talk to us. I hope today has inspired you to think about your diabetes education services you're offering currently and come and talk to us further. It's been a pleasure. Thank you, everyone. Have a great rest of your day.